Everyone, thanks for showing up today after a lively evening, and I hope you didn't finish off the wine when you got back to your room. This is unbelievable. I have the opportunity to introduce Laila Asmal, Dr. Laila Asmal, and I'll tell a story, and I told Laila, I'm going to tell some story about it. She said, you don't know any story about it. Yes, I do. But actually, you know, this really speaks to why we're here. Years ago, I get this email from this person who said, oh, I'm visiting Boston, I'm going to be at Mass General, and, you know, visiting some neuropsychiatrist there. Can I stop by and visit you? I said, okay, like, who's this, you know? And, you know, a few days later, Laila walks into my office, and we sat down, and we had the most unbelievable conversation. And realized that, like, the reason she reached out to me, because she's a psychosis person, I'm a psychosis person. We were, you know, when I was at MGH in the schizophrenia group and stuff. But it made me realize that, you know, like, this is, first, it's all about connections and relationships and building together. And kind of what this organization, for me, stands is like you should be pulling somebody up and you should be pulled up at the same time. And so everybody ends up in the same place. And can Laila just like highlighted that to me? And she reached out because she actually thought that we could help her schizophrenia research and stuff, and I actually was like, oh, tell me about that. Oh, you're doing that? Oh, we really need to try that here in Boston. And so, so anyway, it's a reminder that we can all contribute and everybody can learn from each other. But that one meeting translated into Laila introducing me to Bonga, and then suddenly I had an invitation to visit South Africa. And then, I don't know how many years later, 10 years later or whatever, 14 years later, I've been here 10 times, and you know, and here we are with this organization too. So it really just speaks to getting connected with people, having conversations, being open to possibilities, and see where we can go from there. So Laila, I thank you for that. So now I really will introduce you. Professor Laila Asmal is a clinician scientist who heads the Psychosis Research Unit at Stellenbosch University. Now that's actually a big deal. In the program it sounds, it's just casually mentioned, but that's a big deal. This is a top schizophrenia and psychosis research group. Fantastic group of people. Bonga used to be a part of it as well. And Laila's now the head of it. And didn't even tell me, by the way. I just saw it on the program. By the way. She's an associate professor and earned her PhD examining neuroimaging in first episode schizophrenia in South Africa, which is a very difficult study to do. Her work investigating childhood trauma and neuroimaging in psychosis helped develop her special interest in the biological, behavioral, and environmental factors contributing to psychosis risk and recovery in Africa. Again, like these studies have not been done in many places. So this group is leading the way in so many areas. An experienced neuropsychiatrist with a MSc in clinical epidemiology, and is passionate about raising awareness of the relative neglect of psychosis in the global health agenda. Her vision is a collaborative network of African centers of psychosis research, and I think she can achieve that through this organization. And so, Laila, please come up, and we look forward to your presentation.
Good morning, everyone. Thank you so much for inviting me. I really am honored to be here. This is such an accomplished audience, and I can't believe I'm on this side of the podium. You know, when Dave sent an email inviting me to be the keynote speaker, I honestly thought it was spam and put it in my junk box, thinking it was one of those predatory conference emails. And then a month later, he sent me a WhatsApp like, lady, why have you not answered my email? And, oh, I think I gave him some answer, but that's how honored I am to be here. And with that evil wand to move the thing forward. Ah, there we go. So, my talk is on asking the right questions around diversity, equity, and inclusivity in research. And I'm going to start this talk with a few little secrets. Firstly, this is not the audience to really talk about diversity. I mean, this is the AGMHI. This is kind of why the group was created. So it goes without saying that a lot of what I could talk about would be preaching to the converted, and really it should be a group discussion. So I'm going to move away from the basics of racism and intersectional, kind of like all that stuff. Just going to step away from it and maybe talk a little bit about my experiences as a mid-career researcher. I also would like to say that, if I can figure this out, that some of my work has been published in psychiatry research, but other than that, I'm supposed to say that there's no conflicts of interest to declare, but the truth is I'm full of internal conflicts, and I always find this statement kind of interesting. So I could tell the story about how I grew up in apartheid South Africa, and I went to a underprivileged school for just Indians, but I could also tell the story about how Indian women post-1994 have probably experienced more privilege and gotten higher in the ranks of academia than almost any other group in South Africa. I could tell the story about how I'm a woman and what that means in academia, but I could also tell the story about how I'm actually cisgender, conventionally looking, and, fit comfortably into a room very often. I could tell the story about how I have a disability and how that's affected me. I have a hearing impairment that's moderately severe, and as a psychiatrist, that can be a problem. But at the same time, I have enough bucks to buy a really good hearing aid that allows me to listen to podcasts while they're boring lectures, which is pretty amazing. So, I can carve this in different ways. So there's lots of internal conflicts for me, and I guess I'm trying to say that bias, prejudice, conflicts, it's complicated. I'm middle class. I live in South Africa. And South Africa has a very interesting position in terms of privilege in the African continent. I'm at Stellenbosch University, which comes from, it's a historically advantaged university, and we may be redressing that, as Prof. Olming said, but it's inherited privilege. So it's complicated, that's what I'm saying. And so I'm not coming here with answers, which is a very nice position to take. I'm not coming here with answers, I'm coming here with questions. You're like a guru. What is your answer to the question? But really, I think that if we can leave today with some really interesting questions and self-reflective questions, as we scientists try to, those of us who are scientists in the audience, it's finding the right questions that matter more than coming with the preconceived answers. So that's the first long preamble. The second secret is I just want to be kind of cognizant of the fact that compared to our ancestors, especially our recent ancestors, we've got it lucky. You know, we don't live in a world our parents live in, our grandparents lived in, and if you're in the room today, chances are you can choose to live in a country that has basic civil rights. And I couldn't say that for many of our grandparents and parents. And we all know that there was a time in our not so recent past that we couldn't have made the career choices we made today, for whatever reason. It would have been impossible. But here we are. So there are people outside this room that's going to look in this room and say, you know, look at these privileged group of people. That's they're going to go, I mean, it's a range, early, mid, established scientists that have done well. And I'll never forget, you know, Jimmy spoke about the Fees Must Fall movement, which was this major movement a few years ago in South Africa where students at the universities spoke about a lot of the prejudice that was happening in the universities, and I was part of a march that went to Parliament, and with all these really impassioned students, and there was a street sweeper who we passed by, looked at the students and said, "What are you complaining about?" And of course, that doesn't invalidate their complaints, but I'm just contextualizing, yet again, I'm contextualizing that there's so many ways to look at things. But of course there's also facts, right? So there's also facts that at the turn of the 21st century, 95% of articles published in high-impact journals came from high-income countries. Fact, right? 95%, even though we know where the burden of disease is. We also know, if you look at the United States, that 13% of the population is black, but only 6% of the STEM faculty is black. Fact. And 57% of STEM workers say that they do not experience diversity in their workplace. 62% say they experience active prejudice. Okay, these are all fact. So we have to look at all of this. I'm also going to say a few provocative things, but I'm also, given my own history and the complexity of my own bias coming in, I'd like to say that we should be careful about casting the first stone, so whatever kind of very provocative things I say, we should kind of contextualize that. The very first question, so when I'm going to be talking about asking the right DEI questions, I'm going to look at it from 4 avenues. Firstly, the research team, funding access, research methods, and scientific dissemination. And these are all linked, and we're going to ask questions related to each part of that. But the first question from my MSc in epidemiology is, what is science? Right? Not all of us are scientists, but many of us are, and almost all of us work within the scientific kind of paradigm. So it's really important. I mean, firstly, in a very basic level, science is about trying to uncover the truth through a systematic way of approaching knowledge. Formulate your hypotheses, you test your hypotheses, and that can be quantitative, qualitative, but you test your hypotheses. As you test your hypotheses, you address your bias, and along the way, you refine your knowledge, and you keep testing, keep reiterating, right? The apple falls on Newton's head, and goes gravity, and then 200 years later, I don't know how many 100 years later, they realize gravity doesn't exist in black holes. So what was a truth is now kind of like honed along the way. So if science is that, it is the search for the truth and it is the honing of the truth, then all of us would be working in a wonderful environment, work environment. We'd be working in a community of people that are working together to discover the truths of this world. But that's not the case. And we would all be living in a world where we recognize that the results of scientific study reflect an honest attempt by scientists to describe the world accurately and without bias. And I'd like for you to reflect on the research that your institutions produce. And I'd like you to reflect on this paper that now has over 11,000 citations that shows that the majority of research produce findings of false. And there's Many complicated reasons for that. Amongst them, the sample sizes are too small, effect sizes are inflated, there's bias in the way in which people choose participants, and really the majority of our findings, and I think they re-looked at this paper, and about 80% of our findings that are produced are false. Now, as scientists, 80% of what we're doing, what are we then? Snake oil salesmen, putting stuff into the world. But the thing is, if we were artists painting a picture and saying, it's open to interpretation, that's a different thing. But we're putting stuff out there and saying, this is the truth. And so it's no surprise that people look at our work, and there's complicated reasons why the world doesn't trust scientists. And we see that in COVID. But it's no surprise then when we are so sure that what we're saying is the truth, but the evidence is otherwise, that people still trust us. And this thing is very confusing. I don't know. Okay, so Merton in 1968 stated that the workings of science are social and prone to bias. And I think that this is my takeaway from this kind of set of slides, that the actual science itself is pure, but the workings are social. So the status quo, ask yourself, what is the status quo in research? And think about your institutions. We know that you get more prestige and value from quantitative research, biologically based studies that have sophisticated analyses and look impressive. I mean, MRI, neuroimaging, child trauma, oh, how sexy is that? That's amazing. Highly rated core team and prior success, that looks good. Scientist-driven as opposed to some medical anthropologist-driven. Intersectoral collaboration is really encouraged though, but how hard is that to actually do? And low resource settings, we're gamified to do these little studies, retrospective audits, 20 patients here, 40 patients there, with small sample size, because that's what you can afford. And we know that those are the ones that end up giving you the erroneous results. Right? So then it becomes this perpetuated thing of low impact finding publications. And the large grant proposals benefit from all the hidden benefits of coming with privileged institutions, research admin, statistics support, grant writers, all the things that you as a mid-established early career researcher have to do yourself in low-income countries. So what are the advantages? I mean, it seems obvious, but there's actually, I'm going to have to put up the slide, the advantages to DEI in research design and teams. And the obvious advantage is you have a representative team, but importantly, and what's often not addressed, is that having more diversity addresses explicit and implicit biases. If I have an implicit bias, a hidden bias that I don't even know because I don't even have the language against gender identity, kind of spectrum conditions, by having someone on my team with that, I can address the team addresses the implicit bias. So it's not just about representation, it is actually about addressing these hidden biases. It also means that you're then matching, by having a diverse group, you match the needs of the population to researchers' priorities. So us going in with, let's do positive and negative symptom scores, and you have a patient advocate on your group and go, actually, I'm interested in the quality of life. It addresses knowledge, like I said, around sex and gender. It encourages innovation, and I'm going to go into a little bit more depth about that. And of course, the basics is that you don't have diversity amongst the research participants. You're really going to come up with findings that are not generalizable and has potential ethical and health consequences. And we know what that's like, bringing in high-income countries and scientific studies that are not based in Africa, to Africa expecting it to be translated. The first thing I want to speak about around these 4 topics is around conscious leadership. And Jimmy spoke so much around that yesterday, so eloquently, and I don't want to revisit what he has said, but rather look at things from a slightly different angle. So it really is adding to what he said. Now, the first thing I want to mention is that principal investigators or research leaders underestimate their unconscious or implicit biases. And there are many tests for implicit bias. I can recommend this one, for example, which is a Harvard University test. And I mean, we all know this, that the key is that we all have our biases because of our experience in life. And for example, my bias around gender identity, until very recently, I didn't even have the language in it. I didn't even have concepts around it. When I did the gender identity implicit bias test, it didn't look great for me. But the truth is, I now know my blind spot, which is important. And there are other things around that, around implicit bias for me that help me think around my blind spot. So PIs and leaders tend to underestimate, and this is really important, they tend to underestimate the structural and systemic biases that younger researchers experience as they go up, because they've overcome them. If you're a senior person within an institution, you've gotten there, and you've gotten there over time. And as you've gotten there over time, you've overcome a number of obstacles, but these obstacles change. South Africa now is very different from South Africa 20 years ago. My research leader now, who has 20 years more experience, has had a different life story. And so as a research leader, we have to constantly revisit our own biases, implicit and otherwise, and come from a position of questioning and openness. So part of that is this acceptance that research leaders, consciously and unconsciously, set their agendas in their team. What is said, what is discussed, who speaks, whose voices are heard, whose voices are not heard, what's acceptable in conversation, what topics are acceptable, which research ideas are prioritized, whose ideas are prioritized. All very subtle. And when you come from a person whose voice has historically not been heard, you may not even be aware of it. That's implicit for you. It's an internalized bias, right? You don't even realize that your voice is not being heard very often. And it's something to be aware of. So how do I engage in conscious leadership? There are big things that can be done, as Jimmy explained through his long 15-year history in deanship. But there are also some basic things. So as a research leader, you can look at the talks that are being given in your department. You can make sure that everybody has a voice, etc. And also be aware that as scientists, the choices that we make, and I'd like for all of you to reflect on the choices that you've made over the years, and how much it reflects on your individual career needs versus the careers of those that are reliant on you. So, do you choose what you choose because it benefits you? I like this work environment. This choice is going to give me the grant. This choice is going to make me more likely to be publishable, or is it what is going to be relevant for the scientific literature and the scientific world? So scientists' collective choices determine the direction of scientific discovery. All of us in our room, when we work together as an AGMHI, puts forward scientific discovery, but each of individually, we are living in a social, prone to bias, individual world, and we need to be aware of that. The next thing I'd like to describe is the importance of building inclusivity around gender, age, race, disability, and cognitive disability, or cognitive diversity. Importantly, it's a numbers game. So you can't be in a South African institution where there's 80% people of color in the country and your whole team is white. I mean, you can, because it happens, but it's a numbers game that has to be addressed, but it's also not, right? So you can't have representation of every single issue on your team. You can't have someone who has got gender diversity and is a person of color and is. It's just not going to be possible. So intersectionality is complex. I'd also like to talk about the fact that diversity and excellence, people talk about, okay, diversity and excellence, you can have both, but I especially like to talk about the fact that it is additive. That it's not just that you can have both, but when you have both, it is additive. And a more diverse and inclusive team leads to more innovation. And I'm going to speak to that a little bit. So this is the diversity innovation paradox in science that I'd like to talk about. This was a study done in the US, so it is US-centric, that was done by Hofstra and team, and they analyzed postgraduate studies from the US in science in, I think it was the early 2000s. And it was across, they did this machine learning of postgraduate theses to look at novelty of ideas. And they looked at novelty of ideas versus representation. And they found that if you were less representative in terms of gender or race in a field, you were more likely to produce novel results. So a man in aerospace engineering, not so novel. A woman in comp science, much more novel. A woman in nursing, not so novel. Men in nutrition, good stuff. But it's not an easy thing. It's not just like women across the board will produce more novel things. What I thought was very interesting is when you look at race, white in psychology, not psychiatry, not so novel, which is interesting. Non-white in sociology, lots of novelty. So this is really interesting. But the next layer is the uptake of the novelty. So when you then analyze what happens to the ideas, how those ideas are then translated in the field to innovation, and it's been taken up by other researchers, you will find that the more novel, less represented ideas are actually not taken up that much. Because the overall paradigm within the field isn't open to taking up the novelty of those that are not represented in the field. How powerful is that? That you can have the great ideas, you can produce them. You know, these are not people who just sit around and kind of like just, let's talk about some good ideas. It's produced in postgraduate theses. And then the uptake by other graduates, by their research leaders, doesn't happen as much. So I would argue that diversity and innovation is additive, but you need diversity within the research team and conscious leadership in order to translate the innovation into further excellence. Otherwise, it's not really going to happen. The next thing I'd like to talk a little bit about is equitable service user participation. And there's many advocacy groups in this room that's better able to discuss this. But I just would like to highlight, especially from within Africa, the importance of this, because we don't do that so well. But also the importance of being aware of who we're bringing in terms of representation. The person who's middle class and comes from a relatively privileged background and has schizophrenia, who's a patient advocate, it's important for that person's voice to be heard, of course. But they can't tick a box for schizophrenia advocacy in this country. Yeah? Those are often the people that end up being patient advocates, right? That the people that we most often see are substance users coming from low-income backgrounds who struggle to have a voice, and when is their voice heard? I'd like to talk a little bit about something called the shades of blue, right? And I hope I get this right in terms of my Russian knowledge. But English in Russia, the English and Russian language looks very differently at shades of blue. So we talk about it as shades of blue, and there's light blue, and there's dark blue, and blue is on the spectrum for us. In Russia, are there any Russians in the audience? Not our key focus is the AGMHI, but if there were, I don't know. Ex-Minister of Health was trained there, you never know. But, so in Russia, you have lighter blues, that's a distinct color called Goluboy, I don't know what I'm pronouncing right, and dark blue, which is Sini. And it's as different as red and green. Two different colors. And Russian speakers are faster able to discriminate between Goluboy and Sini than English speakers can differentiate between light blue and dark blue, because it's like differentiating between red and green for them. It can happen in testing, it happens quite quickly. And they can also differentiate between colors that are very similar, like the bottom two colors versus the top big square. They can differentiate which ones are similar much easier and much quicker than we can. And I've often wondered, when I look at something like insight and schizophrenia, and how we just always get it wrong as clinicians, and like, this patient's insight is improving and they're going to take their medication when they leave. And I wonder, my language for insight, I'm not speaking about the same color blue as my patients. And if I'm doing a PANS with positive and negative symptom scale, it's our descriptive scale, using language that was created, not in Africa, but by clinicians, what am I describing and what is the patient hearing and how am I interpreting it? So again, we go back to, we have to ask the right questions that matter to the patient. We have to be truly conscious about advocacy in order to get the right assessment tools. And part of that comes from having a diverse research team. We can't all be people who love the PANS rating scale in our research team, because it ain't going to move from that then. Okay, so the next thing that I want to speak about is something called ghettoization. Ghettos! Oh. Controversy. Listen, I only come with questions, not answers. In my defense. So what are ghettos? Remember these people? Oh man, this terrible past. So for those of you that are not from South Africa, well, first let's just talk about what ghettos are. Ghettos are terms to describe districts or towns or districts within towns or cities that were originally from German-occupied Eastern Europe, and in the time when it was created, the term ghettos, it was to describe Jewish areas in those cities where Jews had to live, and they were segregated from the wider population for their benefit and everybody's benefit, and it was closed, but they were allowed in certain ghettos to physically move out, to go and work, but there were movement restrictions. And from South Africa, heard of this? So this is the South African ghettos, which we had our own lovely name for, called homelands. Doesn't that sound lovely? Right? My homeland. In South Africa, we had 10 pseudo-national kind of territories for black population to live in. And the government classified black Africans as Bantu, so it was called Bantustan. And they were organized on the basis of, complicated ethnic and linguistic groupings. So there's KwaZulu, which is that one for Zulu people, and Trans and Ciskei for the Xhosa people, etc. And the Bamsstrands were a very important administrative way for the government to exclude blacks from the South African political system, and stripping them of their South African citizenship rights. Right? But at the same time creating this veneer of protection and a sense of self-governance. Right? So it wasn't, and that's what was so brilliant, evenly brilliant about it, is that you separate, but it's for your own good, and it gives you the space to self-govern, right? And so in academia, the marginalization, so ghettoization is to treat a particular group, it's been translated into academia now, and it's to treat a particular group in society as if they're different from other parts of society, and as if their activities and interests are not important to other people. But at the same time, kind of important for you still, it's your field, global mental health is really important. You see where I'm going with this? Global mental health is really important. You fight that fight. What is global mental health to an African? It's saying, it's your mental health. It's the mental health you do every day in your clinical practice. It's global, sorry to all the global mental health people here, but it really otherizes what we do every single day, right? And it's not otherizing. To us, this is it. But if you're doing, I don't know, some hair cortisol levels and depersonalization disorder, that's going to be global mental health to you. But that's not where the burden of disease is, in the hair cortisol levels of depersonalization. The burden of disease is sitting with, it's not sitting with the people of this room. No, it's sitting with the people that you're trying to help in this. That's the global burden of disease. So, I think what's tricky about that is, I just want us to remind ourselves there's nothing inherently wrong with global mental health initiatives. And of course, if you look at how it's been done through Boston University and other places, it all depends on intentionality, right? So it's how it's being approached, and sometimes you've got to work within a system to break the system. So I'm aware of that, and not all these systems are the same. But we have to start from a point of recognizing that our system in psychiatry is centered around white, middle-class, cisgender, heterosexuality. And we have to be aware about the otherizing of other fields within it. And what happens when you are a marginalized academic or scientist and you are responsible for addressing transformation? And it's a little bit like what Jimmy was saying about yesterday. It's just, cursing in the darkness sometimes it's so hard to light that candle. And it's a draining choice to light that candle very often. And sometimes we in these committees, the diversity committees, the equality committees at our universities or at international bodies, the International Research Congress body that has a diversity committee, and you think you're lighting the candle, and you think your voices are being heard, but how that translates and what happens at the top is something that can be very frustrating to address. And I just want to acknowledge, again, no nonsense, but I just want to acknowledge that it's a complex thing. And because something is labeled as something, doesn't mean we should take that label as at face value. Because the labels that are meant to be empowering may not always be empowering. Okay. So, moving on to next. talk a little bit about funding access and two aspects around funding access. Firstly, the importance of linking diversity, equity, and inclusivity reporting to funding success, and the importance of when somebody gets a grant to really include DEI in both the application and in the outcomes of the grant, and also on the topic of equitable collaboration between high-income countries and low-income countries, and this is a very complicated thing. So generally, global health research comes with a really important idea in mind, and that is to reinforce economic activity, research competitiveness, employment, and growth. And it should benefit high-income countries and low-income countries, a lot like what Dave was saying earlier. It should be mutually beneficial. But the reality is, a lot of, you all know it, a lot of the initiatives that happen within low-income countries don't get the same benefits as the high-income countries. And some of it is obvious, like, for example, the co-authorship. Some of it less so. Dave, do you remember this? So many years ago, Dave, I went to a meeting, I'm not going to say which African country, but piggybacking on that meeting was we did a little tour with another Harvard group that had done some initiatives in that African country that was research-driven and also empowerment-driven. And it involved HIV-positive women and empowering them by helping them set up chicken farms, like little things. And first, a lot of them chickens died. There's little chicks. Geez, they would send these chicks in a box, and then they had to, they were heating things, and the heating things didn't work, and a lot of the chickens, it didn't go so well for the chickens. That's one. The other thing is there were complicated things around a community that had so little, and then you decide, these people over here are worth putting money in, and it was a patriarchal community, so let's make the woman the breadwinner. So can you imagine the complexities around that? And look at that nice jet plane that we chartered to get in. Hey, we just that's the friendly co-pilot, and that's us coming off. So there we were, jetting in, jetting out. Goodness knows what's the impact, I don't know, Dave, of that study, and the actual social outcomes of it. But I can say with 100% that the people who are running it, and I'm very careful about judgment here, they went in with the best of intentions. Best of intentions, so I'm very careful about judgment here, because they're really, I don't know how you can differentiate good versus not good, but they were good people. I enjoy chatting to them. So African partners speak about being data collectors, of no realistic leadership part. That's really important. You come in, you get a little empowerment, and off you go. And then where now? How do you get from early career to mid-career? Mid-career to establish, making your own voice. And the high-income country prioritizes the project. What the question is, the research question is, comes from there. And you end up in sideline on collaboration, running projects as high-income countries fly in and out. And few people make their stories public. Who are we dependent on? Who are we dependent on for money? And we're going to get onto the money thing very soon. Who are we dependent on money? Who are we dependent on for guidance? So this changed my way of thinking, the Matthew effect. I'm not a Christian, but I really like the saying, for to everyone who has, will more be given, and he will have abundance. But from him who has not, even what he has will be taken away. That's the Matthew effect. Well, that's from Matthew. But the Matthew effect gets translated into science as follows. The personal attributes of scientists affects scientific evaluations. Where you're from, what language you speak, who you know, all affects scientific evaluations, right? Whether that's papers or grant proposals. So publication of research, citation of research, conference submissions. How do they blind, and not this conference, but at some psychiatry congress, you send in an abstract, the first thing they look at is who you are before they look at the scientific content. We know that article acceptance rates are higher when the first authors live in English-speaking high-income countries. And what happens is the unequal distribution of research facilities and rewards shape career trajectories. And we also know, so you're starting off, you get published, it leads to more publications. You get into a conference, you get invited to more conferences. You get a grant, it leads to more grants. It feeds on, that's a Mackey effect. And then you end up in a position where if you're really lucky, we've all had this, right? Where you can do very little and you can be an author on a publication. I mean, we all haven't had it ourselves, but we've seen it happen. Somebody with so outsized recognition for their work. And we can't necessarily blame it because we need that person. As early and mid-career researchers, it's an unspoken secret that you need the research leaders above you to put their stamp next to yours in order to get up. Because not everybody will make you rise with them consciously, and that's conscious leadership, right? Consciously taking you, Bonga Pisa, I'm going to rise with you. But if Bonga puts some other well-known person's name on their article, that person is going to help Bonga rise up. Which, I mean, Bonga's never done that. So let's talk about explicit bias towards high-income research. So this was a randomized controlled trial of 347 English clinicians, so clinicians in England. And there were 4 studies, I'm only highlighting 2 of them and the combined results. And what they did was, it was 4 studies from very different, very well, high-impact journals, so proper, well-regarded studies. And they changed the authorship from a well-regarded university, internationally prestigious university like Harvard or Cambridge, and they changed it to, I think it was one was a Ugandan university, and one was a South Asian university. So they kind of randomized the affiliation of the authors. And what they found was that the person reading it, and so clinicians read the articles, just the abstracts, and they found that where you're from, if it's a good article from a high-impact journal, the person reading it will go, this is a strong article. This is good science, right? So the science is not in question, but whether they would recommend it changes completely based on whether you're high income or low income. And that's the social aspect of science. And you know what matters partly is publication, but how you get to be published, fine. But then what that publication translates into, the innovation that it translates into, being seen as innovative, being seen as worthy of getting presented at a conference, of getting a grant, of collaboration. And that's really important. Now I want to talk about funding. How am I for time? Am I terrible for time? Can I do just a few more minutes? Yeah? I want to talk about funding and the allocation. So firstly, the allocation of US biomedical resources, and this is from research finding that shows that the allocation of funding in the US is strongly correlated to previous successes, right? Which seems fine, but the problem is it correlates to previous success rather than disease burden. And you have to be reflective on is creating the direction of global research, the collective direction of research. We first stand back and go, as a researcher, I come in with my biases. I want to live in Cape Town, I want to work with Jimmy Folmink, I want to be in this research group, and that's how I'm biased towards this research question. But collectively, how are we pitching ourselves as researchers to funders in order for us to get the funding? Because it's not necessarily because of disease burden, it's because of previous success. And there is a systematic misalignment between needs and resources. We all know that, right? The research question doesn't always match the needs of the population. And the funding agencies are often run by scientists within established paradigms. Who oversees the funding agencies and asks them, are you asking the right questions? And so we wonder about the influence of the evolution of science, how globally science is evolving without the oversight and incentives. So if the big funders are high-income countries, who is policing the policeman? Or whatever, I don't know. And of course it is happening. These questions are being asked. You hear it being asked in the MRC, you hear them being asked in the NIH, but is it enough? So the NIH is the #1 global medical funder, $26 billion in a year. These are the last 40 years of directors in the NIH. And again, I want to say that we cannot, just because someone's a white male doesn't mean, I mean, the last NIH director was great. He was a really good man. But this is the last 40 years. We have to acknowledge that. The European Commission, #2 global medical fund. I wish I could give you a bigger slide of photographs, but this is Europe, where they love transparency. So there's lots of little subcategories in their organogram, and it was very confusing to try and figure out what's going on. But everybody's white, just saying, if you look very closely. Just thought I'd mention that. And of course the subcommittees, that's not the truth. But I'm just showing you a trend, right? UK MRC, #3 global medical funder, 1.3 billion. This is the current executive board. So, I just want to throw words out there and put out questions and just talk a little, and just to, I think most importantly, acknowledge that that the feelings that we sometimes feel are real, and the hidden biases that we feel and sometimes can't put a voice to or a language around, it's there. And change is happening, but that doesn't mean that the bias isn't still there. Finally, almost finally, I want to just talk a little bit about research methods and just the importance of finding the right instruments. And the importance within our countries to think about validating our instruments, to think about translating our instruments, and also recognizing how bloody hard that is, and how difficult it is when you're trying to get a study done and move forward in your research career to spend 2 years validating an instrument. Just want to put that out there. And when you deal with complex psychiatric disorders, you're not dealing with one instrument. When you live in a country with many different languages and immigrants, it's complicated. Putting that out there. We also need to discuss the importance of diverse research methods, and the importance of quantitative and qualitative studies and mixed method studies, but at the same time I want to acknowledge that there's very few leaders to mentor and supervise mixed methods around. And the drive in Africa is towards biologically related studies and qualitative studies that sound a little bit, Africa sexy, like let's look at traditional, whatever, let's look at cultural, whatever, something, but it may not necessarily be what the patient needs. Not to say that that's not, that it's sometimes a high-income country preconception of what the question needs to be. We need to match research priorities to user needs, and we just have to think about that in every single project that we do. And we have to be more diverse in our recruitment. The number one barrier to patient participation in studies is the selection criteria. It's not transport, it's not money, it's what the researcher puts in their protocol. And that's something, I mean, it's not to say the other stuff isn't important, but it starts with us. So we really need to think about less rigid study designs. We need to talk about decentralizing trials, where we're going to host our trials, and upskilling in mixed methods. The final thing I want to talk about is scientific dissemination. And I think it's really important that we start advocating for reporting study enrollment diversity and the complexities around that. We need to be less rubbish at reporting our findings in lay press. I mean, come on, we're so bad at it. And that's part of mental health advocacy, and it's a little bit like what Marisa was saying the other day. We have to have our voices out there. I also think it's really important that we need to hold journals and conferences accountable to their role in what issues are being heard in the scientific space internationally and what are not. If we are going to say that this condition, biological slants, get the most space at congresses, that's where things are going to go. If your editorial board is homogenous, they're going to be thinking in a particular way. And we really have to think about equity. I don't know whether that's blinded reviews of abstracts, journals, and conferences. We have to be thinking about non-English. We have to be thinking about the global south. We have to be thinking about no findings. All that research that's sitting in our drawers because nothing was found. And non-traditional methods. And got to move beyond our our special issues. The diversity issue. Of this journal, we are, oh, thank you. And acknowledging the inherent bias in the reviewing process. That comes with it. So my conclusion. So if we're going to be scientists, or we work in the scientific paradigm, diversity is essential for scientific rigor. It's non-negotiable. That change must be intentional to address implicit bias, and it involves all players and stages of the research design, and every single one of us in this room. And research leaders who are inherently, there's privilege in their team, and those with privilege at all levels must be aware of their blind spots. I just want to acknowledge my co-authors on that article, the AGMHR team, which I've been calling the Ahmed team. Ahmed! It sounds so powerful! Ahmed team! The psychosis research unit at Stellenbosch University. All right, this is my reference. Thank you all very much.
Well, thank you for that awesome presentation. I mean, it's relevant no matter where you are in thinking about research. Like every country, this is our own. So we'd like to invite you to Boston to come give this talk because it's just so rich. There's so many things there. So we have a few minutes for questions. Over here.
Thank you very much. A very interesting talk. I thought I'm loud enough, but wonderful. I just want to comment on the issue of the financing. And I mean, some of the stuff you're saying, I have reflected upon myself. But when you think of the NIH or the UK MRC giving out funds, my thinking is like, they're trying to be inclusive by sharing the pot or whatever it is that they have. I forget where it may have come from, like historically. But are they trying to be inclusive in trying to share with others, and therefore, no wonder much of it goes to them first before they give to others? Your comments?
Yes, absolutely. And I think we also, which I didn't raise, but I think it's incredibly, and that's a really important point, I think we need to also hold our own governments and our own scientific funding agencies, if we have them, to task. We need to get our money within as well. I guess the important thing is for us to realize that when the NIH has funding for us, they come with their own agenda, and it is conscious awareness that it will benefit them, and that is their frame. They're helping us, but also to benefit them. And we need to go in with conscious awareness of that how we are positioning our research question is with that in mind. And whether there are biases in our research question and how we're framing our methodology, which patient profile is being looked at, which not, who is being left out, who is being raised, when we frame our research question for a pharmaceutical company or for the NIH, because they come in all, they're not an agnostic, non-biased institution. And it's just about that kind of self-awareness. It's about your own conscious leadership, I think.
Laila, thank you so much for an absolutely amazing talk. I've been so touched right to the depths of my soul since I arrived here yesterday. Things that, really made me think so deeply about my own research. And just a bit of history around the research, particularly in insomnia, is we were trying to place ourselves in the sleep society about how to do it. So we started off thinking, well, we need to do a prevalence study. So, I was assigned that task in 2014, I think it was. And as I began to journey through it, realizing I was kind of on my own, I was a bit like the Lone Ranger, because I was in private practice and many other people were in academic institutions, it became super hard because we needed funding. And so I then tracked forward to where I am right now, and it really takes me to the comment you made about, what do the people actually need and how do we prioritize that? And so my research has taken me right into the heart of just getting to sit down with focus groups and ask people, what does bad sleep mean to you? And it just everything that I've encountered this in fact this meeting has confirmed I'm in the right space. There's so much more, but I did just want to comment on how very deeply I took everything in from what you said. Thank you.
Thank you very much, and thank you for that comment.
Thanks so much, Laila, for that really thought-provoking talk. I think what I'm taking from your talk is the real depth of the difficulty we have as a globe to change, as a global, and for me the global means we all need each other. So a lot of people historically and still today structurally sit with the resources, that's truly on every level. And the other important part of the family sits without. And we've been talking, you've mentioned now consulting the voices of people that you work with. So at every level there should be that consultation. We're talking mental health by consulting now with our clients and bringing the voices of the people with intellectual and psychosocial disability to the table. But when I looked at those pictures you put up, I thought, what a difficult job you guys have. Because there is no way you can know where the need is because you haven't asked. But you've also said we haven't said you should be asking. So that structural problem of being in our own corner and funders funding what they think should be funded, how else are they to know? Where is the conversation? There may be conversations I'm unaware of. Lovely to be here, my first meeting. But where is that conversation about shifting the structural impediments to removing the unconscious biases, the lack of knowing, so that truly we can, as a planet, it's a very small village, we know that. We're sitting in our internet-based universes, thinking we're talking to each other, but clearly we're not. So how did we do that very difficult thing of shifting the spaces that all the players are tightly locked into to address the issues that are real from what you've said, is the question I have.
Jeez, that's a good question. Wow. I'm hoping that today's talk wouldn't lead to disheartening, because I think we're in the flip side of the past few years has been this kind of global consciousness that has arisen, and voices that were previously not heard, increasingly heard. And if we just look at the AGMHI, this is what we're trying to do. And Dave doesn't talk about it, but I've got secrets too about you, Dave. I mean, he's within the NIH, and he's a voice within the NIH, and he, as chair of BU Department of Psychiatry, gets a discretionary fund that he has chosen to put towards the AGMHI, towards this. So it's this that is going to be making the shift. The people who are research leaders or leaders in their field that still keep that link and that awareness that the voices from all levels need to be heard and empowered. And I think that that's happening. I guess it's a lot to hold that is happening, but the other stuff's also happening. I take heart in the fact that we are, within the AGMHI, feel entitled to have a voice. And finding that voice, I think, is the most important thing. You can help one of the portals.
Thank you so much, Laila. It was really thought-provoking talk, as always. And I think for me, the question I wanted to ask you was the issue of sort of citations. You said that people who are perhaps more diverse groups than others do really innovative work, but are not cited as much as the big boys of that particular area. And so I was just wondering about how do we shift that? How do we change that? Because, I've been involved in some work where they've tried to look at, for example, how many percentage of African researchers are on these papers that come from Africa, and they frankly really struggle even just to try and work that out because of affiliations. Some people are from Harvard, but they've got affiliation at Makerere or at UKZN, or so it's very difficult technically to find out these layers of truth. So I was just wondering about how do we get our registrars, our junior researchers, to stop citing the Lancet Global Burden of Disease every time they talk about schizophrenia, and rather look at some interesting, different, maybe qualitative researcher from who's talking about burden of disease in a different way.
That's a hard question. I think as research leaders, we need to do that too. So when we give our talks, we should also be conscious about what we cite. When we write our own papers, we should be conscious of what we cite. We're on any editorial boards. we should be asking these questions. If we're on any conference organizing committees, we should be asking questions. Should we be doing properly blind reviews? I mean, I know that you, Bonga, are part of the editorial team for the South African Journal of Psychiatry, where it's all redacted, the affiliations. And I think we should be thinking about that for higher income, for higher impact journals as well. A lot of them do, but some of them don't. And we should be thinking about that for conferences too. And we should be a little bit more conscious of diverse voices at congresses and not just, let's have a patient advocate at this congress. You know, like the true breadth of cognitive diversity, because we're out of ideas using the old paradigm in science. And to be honest, I mean in psychiatry. And to be honest, I don't have an answer, Bonga, but maybe the answer, I'm all out of answers. Maybe the answers should be from other people. Look, wait.
We're gonna have to cut it.
Thank you.